Hi everyone, my name is Sandra Russo and I will be presenting the neurocognitive disorders caused by TBI portion of our presentation. Okay, so first I want to give a definition of what traumatic brain injury is, and traumatic brain injury is defined as a disruption of brain structure and or function resulting from the application of biomechanical forces. So basically blunt force trauma to your head affecting your brain. And then I wrote people with TBI may have trouble learning and remembering new information and events. And people with TBI may also have problems remembering entire events or conversations. When this happens, the mind will sometimes try to fill in the gaps of missing information with things that did not really happen. On the next slide, I have DSM-5 diagnostic criteria for major or mild neurocognitive disorder due to TBI. A, the criteria are met for a major or mild neurocognitive disorder, and B, there is evidence of a TBI. That is, an impact to the head or other mechanisms of rapid movement or displacement of the brain within the skull. So 1, loss of consciousness, 2, post-traumatic amnesia, and 3, disorientation and confusion, and then neurological signs as well. And C, the neurocognitive disorder presents immediately after the occurrence of the TBI. So amnesia, all of those things happen immediately after. And then persists after the acute post-injury period. Classifications for severity of TBI. So depending on how significant the sustained injury was, that will directly impact the level of TBI. So here we have classifications: mild, complicated mild, moderate, and severe moderate. Outcomes of recovery vary depending on the severity of the TBI. Major and mild NCD due to TBI varies with injury severity and the time since the injury, with the highest frequencies being individuals with the most severe. So prevalence. The prevalence of traumatic brain injury is 59,000 per 100,000 in males in the overall population. Men are approximately 40% more likely to experience TBI compared with women. Concussion in sport is increasingly recognized as a mild form of TBI, as well as resulting from military activities. Development and course. Course or recovery depends on the severity of the injury and also pre-injury factors. Some factors include pre-existing factors, age, prior history of TBI, various mental health conditions, seizure disorder, genetics, and whether or not you receive support, psychological support, care immediately after injury. Because neurocognitive impairments are most severe in the acute period following the TBI. Moderate and severe TBI have been associated with an increased risk of depression, aggression, and also other neurodegenerative diseases. Persisting features of major or mild NCDs due to TBI still varies by age and specifics of the injury and other factors. So, for example, an infant may have delays in developmental milestones. Risk factors: low Glasgow Coma Scale score, midline shift, obliteration of third ventricle, older age, petechial hemorrhages, pupillary non-reactivity, repeated concussions, subarachnoid hemorrhages, and worse motor functions. Differential diagnosis. fictitious disorder, PTSD, and PTSD can co-occur with TBI, especially in military populations. Somatic symptom disorder, prescribed meds, and mental disorders. Treatment: medications, diuretics. This is for more mild TBI. Classifications: SSRIs, over-the-counter pain relievers. For more severe, there's surgery called decompressive craniectomy, and that's where they remove a portion of the skull. Therapies: rehabilitation, CBT, cognitive behavioral therapy, anger management, and counseling. So symptoms of TBI typically resolve within days or weeks of the incident, with complete resolution within 3 to 12 months. It did say that recovery heavily depends on whether or not the individual gets care at the appropriate times. So it's important to do so. The condition can worsen and cause negative thought patterns and other potentially negative outcomes. And that's it. That concludes my portion of the presentation. Thank you.